Today I'm joined by Rita Hitching, a neuroscience writer, editor and researcher with more than 20 years experience in psychology and psychiatry research. Her current focus is on the topic of insomnia, but she has many research interests including the brain, mood disorders, sleep, circadian rhythms and virtual reality. Today we're taking a deep dive into sleep. How much should you be getting each night? What can you do if you struggle to fall asleep or remain in a deep sleep throughout the night? What is insomnia and why are some people affected by it when others have no problem? So if you or someone you love is struggling with sleep, you're going to love this one. Let's get into it. Rita, thank you so much for joining me today. I'm really honoured to have you here, not only as a colleague, but as a friend.
Of course, it's my pleasure. I've been so looking forward to it.
So today we're going to talk about sleep. And so many women our age struggle with sleep, but so many people generally, even kids can really struggle with sleep. Older people can struggle with not being able to sleep. And it's one of those things that actually can make you feel really lonely during the night. It feels like the rest of the world's sleeping and you're the only person who's awake, and sometimes our minds are just racing and other times we don't really understand why we can't sleep. But how much sleep should we be having? What's the optimum? Is there any consensus?
That's a really great question, insofar as that's what people hope to get a kind of snippet of an answer. However, there's actually no such thing. There is no such thing as the ideal amount of sleep, and there's no such thing as, the perfect amount of deep sleep, dream sleep, all manner of things. So in answer to your question, the evidence suggests that actually the amount of sleep that we need varies enormously, depending on life stage, depending on what's going on in our life. But there are some very good recommendations. And so what I'm about to kind of say as the answer to the amount of time you should sleep is based on recommendations from the Australian Sleep or the Sleep Health Foundation. And so for adults, it's somewhere between 7 to 9 hours. And for school-age kids, so kids about 6 to 13, is somewhere around 9 to 11 hours. And for teenagers, somewhere between 8 to 10 hours. So these are general recommendations, and they're recommendations based on what we know is an amount of sleep that kind of is necessary to be able to function well, to be able to think, keep your emotions under check. However, what we also know is that sleeping significantly more than that or sleeping significantly less than the recommended guidelines is also associated with a whole range of different health issues. So if I say to you 7 or so hours, that's just a ballpark figure. Now, you've got to take into account all manner of different things, and that might vary. Does that offer an answer, even though it's not the perfect answer?
No, it does. And so interestingly, tell me a little bit about what happens when you have too much sleep.
Sure. There are typically conditions associated with oversleeping. Okay, and so oversleeping is often atypical, and you'll understand what I mean this from a clinical point of view, and that means that it's not a common presenting symptom, but it's certainly a presenting symptom of conditions like depression, for instance. So it does suggest that perhaps you have a typical type of depression, and therefore you're oversleeping. It's also associated with thyroid dysfunction as well. So things that are conditions, I should say health conditions that are associated with oversleeping are indicative of that. People who chronically undersleep or who have periods of significantly undersleeping may well be associated with, onset of bipolar disorder or something like that. So it just suggests that things are not as they should be. We certainly know that children on the spectrum, for instance, have difficulty with sleep. They tend to have difficulty falling asleep. They tend to, wake up a lot during the night. So anything that's not within the realm of the average suggests that something else might be going on. It's always worth going to your doctor if you're noticing something that it's like, I normally sleep X amount, and then all of a sudden I'm sleeping so much more, or I'm sleeping so much less.
And what are the health risks of undersleeping? So if you're not getting enough sleep on a chronic basis, I mean, I think we all know anecdotally that we're probably going to be not our best selves and we're going to be pretty grumpy.
Yep.
But are there any actual sort of physical health concerns about not sleeping enough?
So not sleeping enough is associated with other conditions that are often lifestyle related, especially if it's chronic. So things like cardiovascular disease, things like obesity, they're associated with, disrupted sleep because they disrupt appetite and so on. So, the system, as you know, is all together. You can't just sort of talk about sleep without talking about its impact on appetite, for instance, or decision making. If you're tired, you tend to be more impulsive in your choices and what you want to eat. You tend to want to eat more carbohydrate-rich food, so you're more likely to gain weight. And so that's, one way the relationship goes. In terms of teens, for instance, it impacts academic performance, which, may lead to perhaps premature leaving of school or other things that might have cascading on impact. So there are both physiological as well as psychological impacts and even lifestyle consequences. But in terms of some of what the research has taken from the lab and what it translates to real life, sometimes it's been difficult to know. So certainly we know that if you undersleep, the immune system tends to be a little bit compromised. As you probably know, there's more release of body repair approaches while you're sleeping. So if you're sleeping less, you tend to have less recuperation. But it doesn't always translate on a bigger scale.
And do you think that we have changed our sleep patterns in recent years? And if we have, is it social media? Is it the fact that we can binge watch TV shows? We don't have to wait for a week till the next episode, or like whenever you're doing your research, or is it seeming like the research is saying that sleep has become different than it was, 20 years ago or 40 years ago?
That's actually a really great question. And there are people who've done historical, looking at historical records of sleep, even from, looking at things where the word break fast comes from, which used to indicate that you had a period of not eating because it was nighttime and so you're breaking a fast. There have been, old scripts showing that there were people that had an initial phase of going to sleep and then would wake up and, kind of tend to the fires and then go back to sleep. I think that our understanding of this idea of going to sleep at a certain time, sleeping through the night and waking up again is actually probably where we're most misinformed. People wake up routinely throughout the night anyway. It's part of sleeping. And I'm not entirely sure that all of the changes that we've noticed are either attributable just to be it light or social media, that is perhaps contributing more. But certainly history shows that sleep has not always been this very clear pattern of go to bed, get up.
Yeah, okay, that's so interesting. So lots of people say they've got insomnia. What is insomnia? Is there a definition?
There is actually an absolute definition. The definition from a clinical perspective is based on the DSM, which is the Diagnostic Statistical Manual, as you probably know better than anyone. And even within the DSM, the criteria has changed over the years. So the current criteria is a period of 3 or more months of consistently disrupted sleep, so happening more than 3 times a week. That is having daytime impairment, whether it's you're feeling like you're not functioning or you're not getting, sort of the ability to deal with your day. And that is impairing and clinically meaningful. Now, there's the addition recently of it being the quality of the sleep. Do you feel that actually you're getting the sleep that's making you feel good? And that being a more important component than how long it's been going on. So in the past, the chronicity was based on 1 month, and now it's 3 months, for instance. So in the past, the prescribing time for medications for drugs, needed to start or could start sooner than it does now. So in terms of chronic insomnia, it's 3 months. In terms of acute insomnia, it's as much as 2 weeks. And bear in mind that's in the context of not having done international travel or something like that. But quality sleep is probably the more important component. Again, back to not the time, but you wake up feeling, I'm ready to rock.
You're ready to rock for the day. And so in terms of what are the common causes that we know specifically are sort of true causes of insomnia?
So again, if we're talking about acute insomnia, so short periods of insomnia, and actually almost all of us will have at the very least one period of insomnia, whether it's something exciting that's happening the next day that's kind of keeping us awake. And insomnia is either a difficulty falling asleep, difficulty staying asleep, and of course the difficulty returning to sleep. So there's both the symptom presentation and then there's a definition of whether it's acute or chronic. So if it's acute, it's under 3 months. If it's chronic, it's more than 3 months. So if you're having any of those things, if you can't get to sleep, you can't stay asleep, or if you're waking up much earlier than you want, technically that's insomnia. And everybody will have a period in their lifetime at some point that they will have insomnia. Now, the triggers can be all manner of things. Everything from shift work, for instance. It could be, not having an opportunity to sleep, which is where insomnia needs to be occurring in the context where you both have the opportunity and the desire. And also, of course, it can be stress. It can be relationship issues. It can be money worries. We know that for men, those triggers are different than they are for women. So for women, it tends to be more emotional and relationship things that keep us awake at night. For men, it tends to be more concerns about finances and health. So there are differences between the sexes as well as things that overlap.
And do women sleep worse than men generally, or is there more insomnia in women than men?
That's another really great question. So women do typically report experiencing poorer quality sleep than men do. And generally, men seem to need more sleep than women, although women do report needing more sleep during their menses period, especially teenage girls. They feel that they need more sleep. And it perhaps accounts for the fact that perimenopausal and postmenopausal women really notice big changes in their sleep because there's a whole hormonal component to that. So women will experience more difficulty getting to sleep or staying asleep. Men do have variations in terms of the amount of time they spend in REM sleep, and REM sleep being that sleep that makes you feel wake up and more refreshed. So they tend to have less REM sleep. So men do kind of feel perhaps a bit in need of more sleep, and they tend to be feeling more tired, despite women reporting it otherwise.
Certainly lots of women seem to report that their husbands can fall into bed and close their eyes and go to sleep and start snoring quite quickly.
So difficulty with onset sleep, which is, one of the aspects of insomnia, is probably less of a case for men than it is for women. But in terms of the prevalence of chronic insomnia, the differences are less there. Certainly women are more risk of getting insomnia over a lifetime than men are. Women certainly have much less opportunity to sleep. There's a lot of competing demands for women. So often a man will go over, perhaps to the sofa and snooze off, and women will be tidying up the kitchen, dealing with children and so on. So women have less opportunity to sleep generally. But, when we do sleep studies, men don't seem to sleep any different than women, even though women do say, "I gets to bed, starts snoring straight away."
And I think the thing as a doctor, what's evolved even over the 25 years that I've been a doctor, is that less and less we want to give people sleeping tablets.
Of course.
I think they were something that perhaps were popular maybe 40 years ago.
Yep.
And, sometimes patients will come to the GP and ask, can they have something to help them sleep? And, we're always struck between that really rock and a hard place of thinking, okay, well, of course the person in front of you is feeling really desperate and they're exhausted and they feel like they're not coping. But the flip side is that unfortunately lots of the medications that were classically prescribed for insomnia are quite addictive. And we also know that the type of sleep you end up getting from them isn't actually great sleep anyway.
Absolutely.
So it kind of knocks you out, but you kind of wake up the next morning feeling pretty groggy and not refreshed.
Yep.
And so it's definitely a bit of a vicious circle. But are there any other things that people can do that we know have some evidence behind them to help their sleep without going down the route of sort of trying to get a prescription for a sleeping tablet?
I think a lot of people take a long time to come to their doctor and ask for help. And often they'll wait and try to self-medicate at home with a variety of different things that are initially helpful and then subsequently not so helpful. And I certainly hear that people would prefer not to take medications. And I'm sure, like every other clinician, there's a time and a space for medications, and sometimes they're helpful. Now, in terms of alternatives, and I think everybody would prefer to have alternatives to medication for the side effects that you've mentioned. The evidence, of course, stands firm and strong on cognitive behavioural therapy. But as you know, that is a tough cookie to chew for anybody. It's one of those treatments that is a bit like going on a low-calorie diet. Heck, it works. It absolutely does work, but it's difficult to do. And it doesn't always have the long-term benefits unless you really stick to some of the recommendations. So
can I just ask you, so what is the approach that you're using in cognitive behavioural therapy to help someone sleep? I mean, I know that's probably $1 million question,
yes.
But what are they actually doing in CBT to try and help someone sleep?
So CBT is actually a multi-pronged treatment. There is a component of sleep hygiene, and so making sure that people have a set up an environment that's helpful and conducive of sleep, because certainly we know that light, noise, temperature contributes to disrupted sleep. So want to make sure that people are sleeping in a room that's, conducive of that. They don't have their TV there, that it isn't disruptive. It doesn't a pile of work to be done or laundry to be folded. So it's a bedroom that actually is designed for sleep. A lot of people have negative associations with the bed, especially if you've been trying to sleep there for a long time. And so trying to change those are one of the key components of CBT, so that, you associate the bed with going to sleep, as opposed to this place where he or she is snoring straight away and I'm lying there waiting for, a light of 1,000 suns to move on so I can get to sleep. So CBT is doing those components, so sleep hygiene, both in terms of education and then, of course, changing the paired associations, the cognitive and the behavioural aspect. And the cognitive is also about, what thoughts do you associate with not sleeping? Are you, for instance, catastrophizing and thinking, that's it, this is the end of the world, I'm never going to, so it's doing that as well. So there's a change both to behavior and to thought processes. And it's a very effective program. It does, of course, also include sleep restriction, so a little bit of sleep drive. So there's a narrowing of the sleep window, reducing sleeping on the sofa, all those sorts of things, no napping, etc. So it's a kind of multi-component, and you can dial up or down depending on, what's the biggest component. And it does work if people can stick to it. Unfortunately, we don't have enough clinicians to go around by any stretch of means. There is a GP-modulated version, which is brief behavioural cognitive therapy for insomnia. But as you probably know as a GP, where's the time to do that? It's actually quite difficult.
Yeah, it's tricky. That's so helpful, though, because I think what a lot of us read to do cognitive behavioural therapy for, menopause symptoms and to do it for insomnia. But I think that was really helpful for us so that people can actually understand what it's actually going to involve and what it's going to be working to change. Because a lot of people will kind of say to me, well, what's the point of going to psychology? What are they just going to tell me to tell myself to go to sleep? People
Sure.
are kind of like, how's it going to help?
No. I mean, there's far more to it than that. And certainly any one component on its own won't work. You can have, the best thought patterns going on. And, if you've got a loud, noisy room and, cars drive, you're not going to go to sleep. So it's like everything. There's all different components to it. And we all tend to fall into bad habits every now and again. So CBT does require refresher courses as well. But yes, you're absolutely right. There's a behavioral aspect. What is it that you're doing? What's your lifestyle like? What are you smoking? What are you drinking? What are you eating? For instance, caffeine, which sounds pretty trivial, but caffeine has a half-life of 12 hours. So that means that the caffeine that you're having at lunchtime, you still have half of that in your bloodstream when you're going to sleep. And caffeine, the ene, is, an antagonist to adenosine, which is exactly what we need to go to sleep. So bear that in mind. Caffeine isn't just in coffee, it's in chocolate and all manner of other things. So that's where, as a clinician, you need to look at all of the different factors.
So that chocolate that you're eating watching your Netflix might well be keeping you awake?
It may very well be keeping you awake.
I also have a lot of patients who will use alcohol because they will say they've got insomnia and the only thing that puts them to sleep is alcohol.
Yeah.
I have to say I'm not a very big drinker, but on the occasion that I do have alcohol, it actually keeps me awake. I feel like I sleep worse. But do we know, is it helpful? Is it not helpful?
Many of us, and I can certainly say this, if you've had a stressful day, you want to get home and you just think, God, just get a glass of wine and just, and so the wine isn't so much for the sleep, at least initially. It's more for the stress as a way of managing that. With alcohol, like anything that's a substance, you need more and more over time. Now, certainly alcohol does have somnogen properties. It does have sedating properties. However, it changes sleep architecture. And that is a fancy word for saying how you go through the sleep cycles. And so alcohol tends to not give you quite as much deep and REM sleep, so you tend to not wake up as refreshed, so you feel more groggy. So alcohol helps with sleep onset, absolutely. It doesn't help with sleep continuation, and it certainly doesn't help with sleep quality. So often if somebody will come to you clinically and say, I have no problem getting off to sleep, but I have difficulty getting back to sleep, have an ask and see if they're drinking, if they're doing any other sort of stuff, because that sort of 2 a.m. waking is often because something sedating has been helpful and then it's kind of worn off.
Sorry, this has just come to me, but obviously in depression, a lot of people get early morning wakening.
Yep.
And so they'll often describe being awake at sort of 3, 4 a.m., just that bit too early. You don't really want to be awake at that time.
Yep.
Do we know why people with depression seem to wake up a bit earlier?
What we do know is the very strong relationship between sleep and certainly insomnia and psychiatric symptoms. For a variety of reasons. Principally, they're geographically in the same brain region, so the regions that govern mood and anxiety also govern sleep. And so people who have difficulty going to sleep typically have underlying anxiety. People that have that sort of 2 a.m. kind of waking time tends to be more of a substance type setup. People who have the 4 a.m. kind of waking tends to be depression. And so both from a presentation of insomnia and a presentation for depression, the two go hand in hand. Now, why is it that people are waking at that time that both have insomnia and often depression with it is not clear. Whether it might be a sense of dread that the day's coming, we're not entirely sure. One thing that, back to what helps and doesn't help, what CBT doesn't help with is the busy mind. And I think that's often what a lot of people report, both with trying to get off to sleep and people who have early morning waking and have both depression and anxiety, is rumination. As you know, people who have both of those conditions, and anxiety and depression is like a coin, where does one side end and the other one begin? Is that over-ruminating about introspection and what's going on? And I think that might be part of the big contribution between both sleep and anxiety and depression is rumination. And actually for that, CBT is not great. So CBT is great for lots of other things, but it really does not target rumination. And that's what mindfulness works very well at. I would actually recommend a mindfulness-based stress reduction program, so an MBSR-based program, as opposed to a CBTI or cognitive behavioral therapy for insomnia treatment for people that have sleep issues. Rather than the other.
Okay. And in terms of the timing of eating, do we have like a definitive answer of how many hours before we try to go to sleep that we should be eating and things like that?
You know what? I think the eating, I know there's a fashion for intermittent fasting and all kind of manner of things. I really think that a little bit like how much water should you drink and how much sleep should you have and how much food should you eat. Do you feel hungry? And do you feel thirsty? And do you feel tired? And, respond to that. Now, we certainly know that some foods contribute and support sleep. So tryptophan-rich foods support sleep. So if you're trying to get to sleep, that glass of milk is really actually a really great idea. A warm glass of milk at bedtime would be helpful for sleep. The cookie, especially a chocolate cookie, perhaps not so much. Now, in terms of timing, having that heavy meal can just feel a bit difficult to fall asleep. So I think, perhaps timing the sleep and the eating at a time where you're not sort of, kind of feeling like you're going to burst. We just sit on the sofa and you just, oh my God. So that always not very conducive of good sleep. But certainly trying to get to sleep hungry is also not fun. The body will kind of want to keep you awake if you're hungry. So find foods that contribute to good sleep, foods that are tryptophan rich, and stay away from foods that are stimulating and have, caffeine and that sort of thing, or chocolate was probably a better example of foods.
One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard, and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment, which is why I've created the menopause appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs, and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight, and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis, and leave you with a comprehensive, tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrshaunaWatts.com.au. So Rita, you've been spending a lot of time researching sleep.
Yes.
So I have a few questions, including why did you decide to study sleep? And also, what have you learned? What sort of tiny niche part of sleep are you researching, and what are you hoping to get out of your research?
Thank you for asking, actually, because, I think it's kind of like your thing, and, it's nice when somebody indulges you to listen to it. The other thing that I fear is that you keep talking far too much about it and kind of bore the pants off someone else. But what I am looking at is insomnia, and I'm looking at chronic insomnia. And the reason why I'm looking at chronic insomnia is, acute insomnia is both common but self-limiting. And, for a lot of conditions, you don't actually need to do anything about them. You just need to give people a chance to kind of manage what's going on and recover. And although there are some short-term impacts from chronic insomnia, they're not near as severe as the chronic impacts of as the impacts of chronic insomnia. So I've decided to go with sleep because after decades of working in mood, depression, anxiety, and trauma, sleep was a consistent presentation. It was a presentation before, it was a presentation during, and it was a presentation after. I spent 10 years in the US at the National Center for PTSD not 10 years at the National Center for PTSD. I spent several years at the National Center. I spent several years at the Veterans Administration affiliated with Stanford. And all of those patients there, irrespective of what they had presenting at the time, whether it was depression, anxiety, trauma, always had difficulty sleeping, both before, as a trigger, as a contributor, while they had their presenting situation, whatever symptoms might be, that was exacerbated by sleep. And even afterwards, if they were feeling better, they might still have ongoing symptoms. So I've kind of started thinking, if I could change sleep, maybe I could touch all of these conditions at once rather than just focusing on one.
Okay, amazing. So what have you found?
Great question. Well, I've just finished data collecting for the trial. So I've been doing a 2-phased research study. So the first phase was actually understanding what clinicians like you, what are the challenges of treating insomnia? And I think you've mentioned one of them, which is a need for a quick fix, a need to help and want to minimize distress. I mean, that's why you went into medicine, is to make people better, right? So if somebody comes to you and is like, I'm really struggling, I'm not sleeping, you want to offer a solution. I've been doing research to understand that and how to solve that issue. But on the other side of it, I've also been asking people with chronic insomnia, what's like for you? What have you tried? What works and what doesn't work? And also, I hate to say it, what has your doctor not done to help you? And what would you wish they could do? And actually, ironically enough, doctors and clinicians will often say, my tool bag is good, but I need more tools.
That's right.
Is that fair?
Absolutely.
Give me more tools. I don't care what the tools are.
We definitely don't have enough tools.
We don't have enough tools. And I think a lot of people who have, and insomnia tends to become very chronic, especially if it's not treated early and promptly. So again, that's why I encourage people, if they're not sleeping and it's a change, go see your doctor. Even if it's a watch and wait, your doctor will know more than you can imagine about what might be playing and contributing to this. But for most people, insomnia becomes very chronic. It becomes very refractory. And often, as you know, with treatments, the more treatments you try, the less people respond. It becomes one of these annoying things. Like if you respond straight away. And so for most people, it's been going on for a long time. So I've been doing that, and, there's been some interesting insights. There's a lot of misinformation out there, both about what chronic insomnia is and when you should get help. And I think a frustration from clinicians about lack of tools, a frustration from clinicians about the funding that's available for treatments, not always being commensurate with what patients need. It's difficult to get billed for talking to a patient and explaining, and, that's not a real easy billable sometimes, but a prescription might be more ready. But from that, what I've also realized is that actually, as I said, mindfulness is more effective than CBT for the rumination. And from there, I've gone on to phase 2, which is I've actually been running an ANZ CTR, so that's an Australia-New Zealand registered clinical trial, which is an at-home trial of virtual reality delivered mindfulness. Now, that sounds like a bit of a jump in terms of the question that you asked me earlier, which is devices and staying awake. What about VR? Isn't that one of those things? But actually, VR is an increasingly validated tool for delivery of psychotherapies. It's been used since the 90s. And actually, you don't use it at bedtime, first and foremost. You actually are using it during the day. So any of the kind of device aspect and light aspect doesn't come into play. Now, the reason why I'm using VR is I've been involved in trials using VR for exposure therapy, treatments for trauma. So as you probably know, prolonged exposure therapy is the most effective treatment for people with a trauma history, especially with complex trauma. And so VR really helps to recreate an environment that facilitates exposure therapy. And of course, people that have trauma have sleep issues, as I said earlier. So I'm using VR to facilitate the delivery, because one of the difficulties with mindfulness is both learning how to do it, sustaining the practice. And of course, a lot of people think that mindfulness, a bit like CBT, is a one-sided component of treatment, but MBSR, or mindfulness-based stress reductions, has several components to it. One is, breathing, meditation, yoga, but then also, of course, a mindfulness aspect that is more about acceptance and not needing to respond and react to thoughts. And that's the component that I'm trying to help people learn and practice with the VR. So that mental reactivity, that rumination, that's what I'm using the VR for. one of the components of the treatment, because most people can do some of the yoga and some of the breathing, but that ability to be in the present moment, not needing to react or respond to thoughts, that's far more challenging. And most of us, even with extensive practice, can do a few minutes at a time, but the sweet spot seems to be about 15 minutes, 2-3 times a week. And it takes a long time to go from 2 to 3 minutes to 15 minutes. But in VR, with the engagement of what you're looking at, you can still deliver auditory treatment, so people feel engaged, and they actually don't notice being in that mindfulness state for that period of time.
Amazing. So I know that you're still obviously knee deep in it all, but are you able to tell us any findings? Is it looking like it may be a viable treatment option, or is it too early to tell?
It is a viable treatment delivery tool, and that's why I picked it. It's an emerging tool. Now, in terms of its usefulness for mindfulness, it's been shown in other contexts. It's been used very well for people with chronic pain. It's been used for people with substance use. It's been used in different populations, combat personnel, as well as community dwelling. It seems to have very few, if any, risks, and they're self-limiting at best, because as soon as you can remove the headset, they go. There's certainly some people for whom it may not be appropriate, and it's nothing to do with aging, ironically enough. That's probably the first thing I can let out of the bag. It's, this idea that older people don't want to use VR or can't use VR is ridiculous. It's actually perhaps people who have photosensitivity or who are more prone perhaps to migraines or something like that. They may be less suitable for VR. And, it's also nothing to do with nausea or motion sickness that you might have heard, especially if you're doing seated treatments. Now, in terms of its use for sleep, I actually don't know, because this is the first trial, to the best of my knowledge, of VR and mindfulness for sleep that's any more than a pre to post. So there have been some studies before looking at the use of VR and mindfulness for sleep with teenagers with chronic insomnia, and that seemed to really help with sleep onset. But that was from one night to the next. That was with a team out in the US. And there's been a team also in South Korea who's done VR for sleep in ICU patients, which, as you know, disrupted sleep is a big issue in the ICU and a risk for delirium, especially with older patients. And that also seemed to be very helpful. Now, in terms of how it works for the general public, I'm grateful for, Hunter, New England residents for trying it, but I actually don't know yet. My hope is that it's promising.
And so I'm just thinking, can patients access this VR treatment for complex trauma? Is that something that people here in Australia can access? Because I'm not aware of psychologists offering that, but that's they?
A fantastic question. And actually, that's my ultimate aim. My ultimate aim is to, bring us more in line with other countries and make it more readily accessible. It is, however, already available here in Australia, and it is available and licensed with the TGA. There is one company in particular that springs to mind, and they're called XR Health. They're they're a US company based in Australia as well, and they provide services under the National Disability Insurance Scheme. And so they do a sort of one-stop solution. I think they send out a headset and they do telehealth and virtual therapy through that. I do think there are other companies that are offering these services, but to the best of my knowledge, XR Health is the only one that has a TGA license to use it here. Now, prescription digital therapeutics are available in other countries. A GP will say, go on this website, use this, whatever. So the DIGGER program in Germany is one such example. We don't have, to the best of my knowledge, a comparable one here. It'd be great to have that as an option. Right now, we're limited to commercially available products, which we don't know if they're available, or we don't know how effective they are. And actually, that was why I ended up using a commercial app in my study, because I was trying to make it as translatable as possible. How quickly can we change it? I don't want to have to wait until, the TGA or, MBS funding or whatever changes its approach. What I've used is off the shelf. You can, go to the Oculus store, buy the app, go to Amazon, buy the headset. So that's the approach I've taken because of those constraints. However, my hope is that in the future, your tool bag may well include not just VR, but a whole range of other tools.
Amazing. Now, as you know, I've got quite an interest in the peri and postmenopausal period. And I have to say, trouble sleeping is probably one of the most common complaints that I have. And what's also, I would say, quite remarkable is how well these people respond to hormones.
Yeah.
It's literally like you've given them $1 million. They
Absolutely.
come in, they kind of will often skip into the consultation a month later and they'll just be like, I've slept. I slept all through the night and it was amazing. And I think anecdotally for years, we've never really thought of estrogen and progesterone and testosterone as being anything to do with sleep. They've always been sort of labelled as the sex hormones, and people have always thought of them about babies and eggs and sperm and sexual characteristics. But sleep is definitely much more complex than we ever thought. And there's much more things at play clearly than we've ever thought before. I just wonder what your thoughts were on that, and did you have any other little tidbits or anecdotes around that sort of middle-aged woman who's struggling to sleep?
Again, I think what I've said before, if there are changes that are different from where you're at and what you are comfortable with, and if you're not waking up refreshed or you're not having the type of sleep that is helping you function, get to your doctor. I think that would be my first recommendation. Now, in terms of your question about hormones and estrogen and so on, absolutely. So estrogen is really important for quality sleep. It really impacts the amount of time you spend in REM sleep. And so even if you don't get a big change in the amount of sleep that you're getting, you will get better or more restorative sleep. So I'm not surprised that you're getting women coming in, can I just hug you? Because not only am I sleeping better, I'm waking up refreshed. So as I said, less about the amount and more about the quality. And estrogen really changes sleep architecture. A little bit like I said with alcohol, reducing the amount of REM sleep and you waking up groggy and feeling horrible. Estrogen actually increases the amount of time you spend in REM sleep, and so you wake up feeling more refreshed, even if it doesn't always change the amount of time. So absolutely, I think if it's something that, a woman's willing to try and interested and it's appropriate for them and you could make that decision on their behalf, it's certainly beneficial.
I'd love you to tell us, because obviously you spent such a long time taking a real deep dive into this subject, but any practical tips? Like sometimes people feel like, I think they want to be really warm in bed.
Yep.
Or they want their bedroom to be really warm and really cozy. But my understanding is the evidence suggests actually in ways the opposite. Like obviously you don't want to be freezing, but you actually are meant to have a room that's probably a bit cooler than people would expect. Is that right?
Absolutely. So actually you want to be in a cool, dark room. Okay. And the reason for that is it slows down the heart rate and it sort of prepares the body for sleep. And going to sleep in a hot room kind of makes you uncomfortable. You know how it's like the heat of summer, it's difficult to sleep. So you want to find a cool, dark room. Now, if you're somebody who struggles with cold hands and cold feet, and certainly a lot of women do report that, we want to move heat away from the core. So, get something to warm your feet and warm your hands, but have a cool, dark room. And so that would be one practical recommendation, in addition to the ones that I've said earlier, which is make your room enticing for sleep. If it's messy and you just don't want to go there, it doesn't feel like you're going to go to sleep. It's kind of like nice bed sheets, a clean room. I mean, we all know what that is. And I think some of us struggle to do that. And I get that. But the practical is make a room that's conducive of sleep. A cool room is best. A dark room is best. And, keep a regular sleep routine. That tends to both, get your body and mind ready for sleep. If you've ever tried to go to sleep 2 hours early because you need to get up earlier, you just can't get to sleep. Your body's not used to that. So keep to a routine. You can't bank sleep. Sometimes you think, all right, I'll just get extra sleep, but it doesn't actually work like that. So keep a regular routine. Make it a bedroom that you want to sleep in, cool, dark. Take heat away from the core towards the extremities, and get comfortable. And just change your mindset about sleep. The reality is some people take longer to go to sleep than others. Some people, wake up earlier than others. There are owls and there are larks. There's a chronobiology component to sleep. Do some of the mindfulness aspects so that you're not needing to react. But if you do wake up, don't beat yourself up about it. What use could you do of this time? Could you just let here and just sort of feel cozy and comfortable and let it go?
Rest your bones.
Rest your
bones.
bones.
Just rest your bones.
Yeah.
I think one of the other things I often say to patients is if you know that you have late night phone calls with people who wind you up or put you on edge or whatever, politely try and shift that phone call to a different part of the day. If you're going to be going to bed and you're literally arguing with someone in your mind, you're never going to be able to go to sleep.
Absolutely. And women in particular are very sensitive, as I said. Big triggers for women are emotional aspects. We're more emotional. And, a lot of men, of course, it's financial stresses and financial worries about work and so on. Of course, the other thing is the body and mind need to be in sync. So if you've ever tried to go to sleep when you've been sitting all day but you're mentally tired, it's difficult to get to sleep. You need to also be physically tired. So try and get some exercise. And it doesn't have to be anything that's out of what you can manage. I once went to a CBT training and I remember a clinician said, I can't get any of my patients to do any exercise. And they said, just walk out the door, 5 minutes in one direction, 5 minutes back. Get out in the morning and get some sunlight. Help your circadian clock. It does have a critical window. It goes away by about 9:30.
So tell us a little bit about this circadian clock. What do you mean by that?
So the body has a master clock. Actually, if you were to go directly above the roof of your mouth, there's a kind of, what they call the master clock, the circadian clock. And our circadian clock is about 24 hours, actually slightly longer than 24 hours. And we know this because people have been prepared to lock themselves in the dark for several weeks, and instead of it being 24 hours, more like 24 and a half, 25 hours. But basically, we go by the moon and the light in the day. And usually we get up when it's light and we go to sleep when it's dark, and as do most every other animal, or at least mammalian animals. And not only do we have a master clock, every cell in your body has its own clock, as you know. And there's a master one that sends messages to say, and now we go to sleep, and now we wake up, and now we restore. And so that is guided by light. And we know from our retina that not only can we see color, of course, we can also see shade, light and dark, but we've also got photosensitive cells that directly go to the circadian clock. And so it will know even if you can't see. So a blind person can get insomnia. And so our circadian clock is governed by our eyes. But it does have a critical window of lux of when it can capture that. And 9:30 in the morning seems to be about the window. So get up early, go for a walk, get some light in, nice bedroom, nice sheets, cool room, heat away from the core. Don't schedule phone calls with annoying people late at night.
Rita, I have patients who have chronic insomnia, and then we finally get them sleeping and they're really happy, but they still feel exhausted. Is it a bit like being overdrawn at the bank, where it's going to take time to pay back the overdraft because you've had all these months or years of sleep deprivation? Or should it be that sort of within 2 weeks of sleeping really well that you should have built up all your reserves again? Do we know that?
Remember that there is sleep quality, and actually that's what matters more. And so if people are coming in saying their sleep quality or they're not feeling restored, it's well worth having a good check to see what else might be going on, thyroid, etc. But certainly it's the amount of time that they're spending in REM sleep that seems to contribute more to that restorative component. You can't force people to, shoehorn into more REM sleep. These online calculators that say, you've spent X amount of time doing, REM sleep, non-REM. I mean, the body decides what it needs and when it needs it. So I guess if people are still feeling like they're not getting good quality sleep, try and dig down and see what else might be going on. Maybe it is the estrogen, for instance, that actually will increase the amount of REM sleep, and so you feel like you're getting better restorative sleep. I think sometimes people feel like if the numbers match, then it's good. If I'm there and it says 8 hours, why do I still feel tired? Maybe you need more than 8 hours.
Yeah, maybe you're a 9-hour girl.
Yeah, and that's okay. Just need to accommodate for that.
And it would seem remiss to have a whole conversation about sleep without talking about screens even a little bit.
Sure.
Are screens really bad for our sleep, like phone screens, iPads? Is there any good evidence that tells us, is it to stop 1 hour before bed or 2 hours, or what is the recommendation? Do you know?
Actually, the evidence is not as clear-cut as you might believe, as it always is the case. It doesn't seem to be that it's just the light. If anything, actually, most of the research would say that the light itself doesn't make much difference. There have been studies, again, people are brave, where we've had teens where they have, a device like a phone that emits light, and their sleep onset's slightly delayed, but not very much. But if you have scrolling, engaging, texting, messaging, that does make an impact. And so it seems to be that it's engagement rather than the light itself. We're already living in a world where there's light all the time. And so our sensitivity is perhaps a little bit blunted already. So it isn't so much the screens or the devices as much the level of engagement. Now, like everything, some people are more sensitive than others. And certainly keeping a device in your room that's pinging messages is not a great idea. So in line of what we were talking about, a cool, dark room, don't keep your phone in your room if it's your alarm. I'll often hear people say, but I'm going to need it as an alarm. No, get a standard alarm and take your phone out of the bedroom, or at least silence the notifications, or, something else. So it's the engagement. As far as the evidence is probably slightly weighted on the side of that.
Amazing. And so what's one thing you wish everyone knew about sleep?
That it's okay not to sleep. Unless you have familial inherited sleep disorder, no one's going to die. It's normal to wake up at night. This idea that you go to sleep, you don't wake up again until the next day is not true. We wake up all the time. We toss and we turn, and some nights we have better sleep and some nights we have poorer quality sleep. Do all the practical things, and then if it's still not getting the best night, think about what could I do while I'm here that makes me enjoy this moment.
Amazing, taking the pressure off the whole thing. Rita, you have been so helpful and so knowledgeable. We ask every person who comes on the podcast one question,
yes,
which is, what is the piece of advice that you would give to your 20-something self? It doesn't have to be about sleep, by the way. It can be about anything.
Actually, this is the question I've thought about the most, and I'm hoping that you'll forgive me a little when I say that I want to change the date.
That's all right. Go on.
The reason why I say this is, I don't know about you, but we've all had periods in our lives where things have perhaps been less good. And 20 was not the worst for me. 16 was really bad. So I would like to write a letter or some note to my 16-year-old self rather than my 20-year-old self.
Okay.
So in the context of that, I'd like to tell her that it's okay to be different. It's okay to look different. It's okay to sound different. There will come a time when people will want to inject their lips. I used to have even now, but certainly then I had very big lips. And people used to tease me mercilessly about it.
Wow. And you were just ahead of the fashion. You were ahead of the curve.
I used to stick my head out of the window of the car and hope that the wind would dry them. And now people do it. So it's okay to be different. It's probably what I would say. And hang in there. It was a difficult time for me.
I think 15, 16 can be pretty hard for many, many people. Rita, thank you so much.
Oh, it's
you
been
have
a
been
pleasure.
fabulous.
Absolute
And
pleasure.
I'm hoping everyone listening has gained some knowledge, because I think in reality we read about things like sleep hygiene or we read about CBT, but you've been excellent at really explaining to us what those things mean. So thank you so much.
My pleasure. There's so much more to learn. I've actually quite fallen in love with sleep, even though I hadn't anticipated. So thank you for the opportunity.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.